Good evening. I hope I'm audible and my slides are visible.
Yes, sir.
Okay. Honorable chairpersons and dear friends, at the outset, thank you, Dr. Ashutosh Mishra and the entire Cardiabcon team 2021 for inviting me today to talk on a very novel and provocative topic, the cluster of prediabetes and its implications in the prevention of diabetes and its complications. We all know that type 2 diabetes is a complex disease that progresses through three states: a normal state, a pre-disease state, or what is known as a critical transition state, and the disease state. The key issues that I would like to discuss today are: do all the patients with pre-diabetes behave the same way? Can we identify this so-called pre-diabetes state or pre-disease state and stratify according to the risk of progression to diabetes or its complications? What drives the change from pre-diabetes to diabetes? Can we prevent this change by pharmacological intervention, and whom to treat? But having said this, let me say at the outset that all patients with prediabetes should undergo intensive lifestyle modification. Now, there are certain caveats. Prediabetes is also known as intermediate hyperglycemia or non-diabetic hyperglycemia. It is a high-risk metabolic state for diabetes, defined by glycemic variables that are higher than normal but lower than the threshold for diabetes. However, the current definition of prediabetes neither reflects subphenotypes of the pathophysiology of type 2 diabetes, nor is it predictive of future metabolic trajectories. It was in 2010 that ADA adopted an A1C criteria of 5.7 to 6.4% to define prediabetes. The lower bound criteria of 5.7% was based on the modeling of the estimated composite risk of development of diabetes and cardiovascular disease using cross-sectional data from the 2000-2005-06, the National Health Survey study. But the glycemia of prediabetes is not independently associated with cardiovascular disease, but is only a risk factor for the development of diabetes. The near twofold higher unadjusted risk for cardiovascular disease in people with prediabetes is driven mainly by abnormal levels of conventional cardiovascular risk factors. While HbA1c adds minimally to CV risk prediction, those with prediabetes should have the conventional CV risk factors appropriately measured and managed. There is no obvious lower threshold. The risk starts to increase beginning at a fasting plasma glucose concentration of around 80 to 87 mg/% and progresses in a curvilinear fashion. Compared with the gold standard 2-hour glucose criteria of 140 to 199, a fasting glucose of 100 to 125 lacks specificity and results in many false positive diagnoses, wherein A1C of 5.7 to 6.4 lacks sensitivity and results in false negative diagnosis. We all know the numbers: A1C 5.7 to 6.5, fasting 100 to 126, and a PP or IGP, a postprandial of 140 to 200. Global burden: 230 million people had diabetes in 2003. More than 300 million people had estimated to have prediabetes. By 2025, it is expected that 500 million people will have prediabetes. Southeast Asia currently has the highest number of people. By 2025, it is estimated that we continue to have the highest prevalence of diabetes, 13.5%, followed by Europe. Now, the two facets of the prediabetes, the impaired fasting glucose and the impaired glucose tolerance, are not clinical entities, but rather risk factors for diabetes and CVD. And they are associated with physical inactivity, obesity, especially abdominal or visceral, dyslipidemia, the classical high triglycerides and low HDL, and hypertension. Now, how do we progress? It is seen that persons with IGT, 46% are likely to proceed to diabetes, whereas 24% will revert. And as far as IFD is concerned, 38% will proceed to diabetes and 38% will become normal. However, if you look at the age-wise, this was a wonderful study of more than 3,400 patients. If you look at the prevalence of diabetes in people with 75 or more than 75 years, it is quite high. 29% if you take the A1C, 59% if you take the impaired fasting, 73% for both impaired fasting or fasting, and look at the variations in the prevalence of diabetes. But when you look at the progression to diabetes, it is hardly 3 to 9% depending on the criteria chosen. And during the 6 years of follow-up, death or regression to normoglycemia from pre-diabetes was more frequent than progression to diabetes. The conclusion being that pre-diabetes may not be a robust diagnostic entity in people with more than 75 years. At that age, you can forget about pre-diabetes. And what is the level risk of progression to diabetes? Depending on the A1C levels, the higher the A1C levels, the higher the risk. And besides the progression to diabetes, we know that microvascular complications are supposed to start at the onset of type 2 diabetes, but unfortunately, we have seen it even before the onset. And 50% higher risk of cardiovascular disease, coronary artery disease, and stroke. CVD risk is 3.2, higher adjusting for all the other variable risk factors. Now, this is the latest update published in BMJ 2020 regarding the cardiovascular disease, a meta-analysis of 129 studies with more than 10 million patients. The all-cause mortality associated with pre-diabetes was 13% more, and composite cardiovascular was 15% more, 16% was coronary heart disease, and 14% stroke. Impaired glucose tolerance carried higher risk of all-cause mortality, CSD, and stroke than impaired fasting glucose. And the figures were much higher if the patients had known atherosclerotic cardiovascular disease. So pre-diabetes is associated with an increased risk of all-cause mortality and CVD in the general population, and more so in patients with atherosclerotic cardiovascular disease. But besides this, what Dr. Ruchi was talking about, the cardiac autonomic neuropathy in pre-diabetes, 6 studies have shown a prevalence of varying anything from 9 to 39% in pre-diabetes. Now, the long-term consequences, hypertension, malignancy, and Alzheimer's disease. So, should pre-diabetes be taken seriously? We all know hyperglycemia is a continuous risk factor for adverse outcomes. Both the degree and duration of hyperglycemia are associated with the development and progression of diabetic micro and macrovascular complications. And there is a delay of 3 to 8 years between the onset and the diagnosis of type 2 diabetes. At the time of diagnosis, as many as 8 to 16% of patients have diabetic retinopathy. 17 to 22% have microalbuminuria, and 14 to 48% have peripheral neuropathy. And these are microvascular complications. And this is a recent epidemiological analysis from the UK, which was shown that in patients with new onset diabetes, there were already a hazard ratio of 1.76 for retinopathy and 1.14 for nephropathy. Now, this was a wonderful study that was done from the main health informed exchange workflow in the United States, and they took and looked at the population of more than 1 million, and they took out the cohort of more than 7,300 patients who had new onset type 2 diabetes. And they discovered that each of these patients, when they were followed up in the previous 6 months, there occurred a particular critical period where there was a very high entropy and very high risk of developing type 2 diabetes. And through the various algorithmic pathways and modules and Markov process, they found that there is something called a dynamic driver network that drives the patient from the transition state into the disease state, whereas majority of patients may go back to the normal state. So the results indicate that there is a critical transition that could be detected 6 months before type 2 diabetes confirmative diagnosis. Unlike the detection of the disease state, the dynamic driver network enables the identification of an intermediate or transition state that generally has no clear metabolic abnormalities, but a future trending of deterioration. Can we try to identify this particular transition state so that we can do some intervention? Now, here it comes the story of clusters in prediabetes. And this was a paper published just last month. The Wagner R et al. From Germany, they distinguished 6 different subtypes of prediabetes, tracking data from an intensive 25-year-old longitudinal study. And each of the 6 prediabetes subtypes were distinguished by specific metabolic parameters and results in different long-term outcomes. And they validated this data with another longitudinal study known as the Whitehall 2 study from the UK, and they were followed up for 20 years. And these findings were replicated in an independent cohort, giving us a perfect answer. So the 6 subtypes accurately fill that large data set, affirming that prediabetes can be distinguished into separate disease stratifications. And what are these prediabetes classes? If you look at this, we have clusters, and this was based on variables derived from OGTT, MRI measured body fat distribution, liver fat content, and a genetic risk in a cohort of extensively phenotyped individuals. And clusters 1, 2, and 4 were at a very low risk of diabetes and low mortality. In fact, the 2 was normal weight, 1 was underweight, and 4 was overweight, but all had metabolically healthy parameters. If you look at cluster 3, it is a high risk. These people had low insulin secretion and a very high genetic risk, a high diabetes risk, high cardiovascular risk, and a nephropathy risk. If you look at cluster 5, they had a high risk and they had a very high liver fat, insulin resistance, a very high diabetes risk, high cardiovascular risk, high nephropathy risk, and a higher mortality. On the other hand, if you look at cluster 6, though it was high risk, it had high visceral fat and high renal sinus fat. They are relatively low risk of diabetes, but high risk of nephropathy and a higher mortality. And the proof of concept study demonstrates that the pathophysiological heterogeneity exists before the diagnosis of type 2. And there are 2 types of individuals. One with an increased risk of complications without rapid progression to over type 2 diabetes, and the others who have increased risk of complications with rapid progression to diabetes. This clustering approach is not designed to provide definitive subphenotypes for individual patients in a clinical setting, but this approach is useful for characterizing the metabolic heterogeneity prior to clinical manifestations of type 2, and the identification of such subphenotypes suggests some potential therapeutic implications. However, we must recognize the limitations of the study. This were done in the Caucasians, so it is not, we don't know whether it's applicable to the Asian Indians or not. And the variables selected may not be ideal, and there were high attrition rates in the study. Now, before I go to what are the therapeutic implications, let's see what we know so far about how to treat prediabetes. We all know that lifestyle is one of the most important interventions that we can make, and it has an effect even after 20 years. Various drugs have been used, out of which metformin is the only one that is approved. But we must not forget pioglitazone, which showed an 81% risk reduction. And this intervention provides, unfortunately, increased adverse effects with some drugs. Now, it was the DeFronzo who showed that bio reduced the risk of diabetes, albeit with significant weight gain and edema. And 18 participants were needed to be treated for 1 year to prevent 1 case of diabetes. But we had a lot of pleiotropic effects. The diastolic blood pressure improved, HDL cholesterol, liver enzymes, and there was a slowing of the progression of carotid edema media thickness. So pyridosine is another drug that one has to keep in mind. But when you compare metformin and lifestyle, of course, lifestyle scored over metformin. Now, this was the studies by the Prediabetes. After that came the Diabetes Prevention Program outcome study, where everybody was given metformin. And this 51-year-old study showed that the metformin treated group showed significantly less development of diabetes in certain groups. And who were these? Who had a higher fasting plasma glucose, that is 110 to 125 versus 100 to 109, in whose A1C levels was higher, 6 to 6.4%, then less than 6%, and in women with history of TDA. So the higher the risk, we must think of pharmacotherapy and even metabolic surgery in patients who have proper indications if the BMI is more than 40 or more than 35 with severe parameters. Now, why metformin? Metformin provides potentially an 8% absolute reduction in the risk of development of type 2 over 30 years, reducing the cumulative lifetime glycemic exposure. So it prevents complications or delays them. It is inexpensive, and we have 60 years experience with metformin. It reduces both cost and improves health outcomes. And it is reasonable that if we use it in selective group, we are going to get the desired benefits. We have been using supplements like cinnamon, chromium, alpha-lipoic acid, beta-melon, and these are being marketed. And there is no scientific evidence to use this, but we are afraid to use metformin. And who are the persons who will benefit with metformin? People with less than 60 years of age, BMI of more than 35, greater degrees of fasting hyperglycemia, and history of TDA. And this is known as the benefit-based tailored treatment, which calculates an individual's absolute risk reduction as the difference between the individual's risk without treatment and with treatment. Now let us look at the vitamin D also, which has been a lot of aura has been created. And this is a double-blind randomized trial with 4,000 international units vitamin D3 versus placebo in patients with pre-diabetes more than 2,400, overweight, and they looked at progression to new onset diabetes. The risk of new onset diabetes was not significantly lower. So vitamin D acts as a placebo. Now coming to the therapeutic implications of clusters, let me go back. We know so far lifestyle intervention and metformin. Now if you look at cluster 1, 2, and 4, they require only lifestyle modification. Cluster 3 might benefit from a standard aerobic exercise and dietary calorie restriction by reduction of visceral fat and individuals. Cluster 5 are at imminent risk for diabetes, and they benefit from high intensity dietary and or lifestyle interventions aimed at weight loss and liver fat reduction. The clusters 3 and 5 have elevated genetic risk as non-modifiable risk factor, but the cluster 6 is somehow there is genetic predisposition to protect it from development of type 2 diabetes. As I said, the cluster 6 have a very low risk to protection for progression to diabetes. So when risk stratification is done, their progression to diabetes can be ignored. Insulin resistance with or without prevalent prediabetes are associated with renal disease, elevated mortality in cluster 6, and that means that we must take it seriously even with low glycemic progression. What are the drugs we should be using? At the moment, as I said, FDA approved metformin in cluster 3 and 5, but cluster 6 role is doubtful since there is low risk of progression to diabetes. Off-label, I talked about pioglitazone. CV reduction proved possible role in cluster 3, 5, and 6. Again, off-label, but with a very high potential, SGLT2 in 3, 5, and 6. Now, these two drugs, the PIO and SGLT2 inhibitors, are off-label, but they're wonderful drugs and can help prevent cardiorenal complications. But having said that, whenever you're using any off-label drug, remember to have a judicious selection of patients, no contraindication, shared decision-making, education of patients, and pharmacovigilance. To wrap up, The key messages are pre-diabetes needs to be further classified for risk stratification. Not all patients behave similarly. Strategies to screen for pre-diabetes and assessment of individual risk factors is the need of the hour. All patients with pre-diabetes should be consulted for intensive lifestyle modification. Clustering of pre-diabetes is a novel and emerging concept. We must recognize the heterogeneity, and metformin is very good, is very well going to work in patients who are younger, more obese, more hyperglycemic, and histories of GDM and cluster 3 and 5. Looking beyond the guidelines, think of PIO and SGLT2 inhibitors. They are going to be of immense benefit in cluster 3, 5, and 6 to prevent cardiorenal complications. Thank you for a patient hearing.